Thank you all for coming out this evening. It's a great opportunity to have a chance to talk with you tonight about why public health matters and why we need public health today more than ever. 2016 was the first time in U.S. history that life expectancy declined in the U.S. not 1, but 2 years in a row. This is in the setting of having the most expensive healthcare system in the world, with the worst outcomes of any industrialized democracy. Part of this is related to the opioid epidemic, which is tied to depression, anxiety, and economic loss, along with many other social forces. But U.S. healthcare is in a crisis. We've seen this crisis before. The last time U.S. life expectancy declined in the U.S. was 1994, at the peak of the HIV/AIDS epidemic. That was also a disease met by fear, stigma, and denial. We just hoped it would go away. But the problem grew and grew. Communities mobilized. Doctors, nurses, social workers engaged. Advocates spoke up. Scientists started to find solutions. Healthcare systems were developed. And HIV/AIDS is not the problem that it was 20, 30 years ago. If we can end the global HIV/AIDS crisis, we can end this crisis here today. As Mike and Bob mentioned, I grew up in Portland, Oregon. I went to Lincoln High School. My first class was at Portland State University, Calc 2. My first job was at OHSU in a neuroscience lab. I love neuroscience. I'm studying the brain. What could be more exciting than that? I went off to college, I worked hard, and I secured 1 of 5 full scholarships to pursue a medical degree and a PhD in neuroscience. My dream was to become a neurosurgeon, even cure brain disease. And I thought I was all set. Little did I know that East Baltimore would change all that. Drove to East Baltimore in my 1979 Toyota Celica. Sylvia, remember that? Sylvia, Roger, Mosley, friends of the family. Drove up my 1979 Toyota Celica, and my first stop was a medical school housing office to find a place to live. I went into the office, and there was this bulletin board with landlords wanting to rent to students. Wrote down a few names, phone numbers, made some phone calls to see a few apartments. Went out of the housing office, went to my car. Where are my keys? Door is locked. They're in the ignition. Oh no. What am I going to do now? There's a young man on the street corner. He saw my predicament. So he came over. He had a backpack, and he pulled out a Slim Jim from his backpack and went, door was open. I said, wow, thank you. He says, no problem. Happy to help. You seem like a nice guy. How would you like to come over to my place and smoke some crack? That's really generous of you, thank you. But I got to meet my landlord, and I don't want to be late. Maybe another time. Started medical school, and there comes that time in every medical student's career where you have your first patient. My first patient was Anthony. Anthony was a tall, muscular African-American man with endocarditis. This is an infection of the heart valves, often caused by injection drug use. The young doctors on the teaching service would call patients like Anthony a dirtball. My job as a third-year medical student was to walk into Anthony's room, to record his vital signs, ask him how he was feeling, and do a physical exam. I am terribly embarrassed to say that I was scared to walk into Anthony's room. But I walked in my short white coat, and Anthony said, "Good morning, Doc." I said, "Well, I'm not really a doctor. I'm just a third-year medical student." He said, "I don't care. You're my doctor." Anthony greeted me with intelligence, appreciation, and I would soon learn an amazing sense of humor. But I was confused. Why was this a patient that the young doctors were calling a dirtball? So I went up to my chief medical resident and I said, "Could I follow every patient who comes in with endocarditis?" He looked at me and said, "Sure, I guess so. No one else wants to." And so I did. That month, I followed about 15 patients, all with endocarditis. None of them were exactly like Anthony. All had different stories, but each of them had a rich, compelling, and often tragic story. It was that month that I first realized I was a racist. As a white person of enormous privilege, this is a topic I need to address with humility and recognize I was slow to start learning about racism, and I'm still very much learning. And acknowledge the millions of people who have suffered from and fought against racism. But I had no idea that I was a racist growing up in Portland, Oregon, where I thought that everyone could dream of becoming a brain surgeon, even curing a brain disease. Little did I know that I could have and act on that dream because I grew up in the West Hills of Portland, Oregon, and not East Baltimore. And I would learn that where you're born not only determines where you go to school and what professional opportunities you have, that being born in a good versus a bad neighborhood is the difference between rich and poor, often black and white, in 25 years of life. And that's not right. And that's why public health matters. The other thing happening in Baltimore at this time is there was this new disease called HIV/AIDS. We didn't really understand how and why it made you so sick, but we knew that after a diagnosis, you had about 6 months to live. I started testing injection drug users and gay men in a free clinic. I tested 8 people HIV negative before I met Paul. Paul was a young 18-year-old gay man who came in because his friend said, "You got this cough, it's not going away, you got to get tested." I sat Paul down, he was clearly nervous, and I made an inappropriate, awkward joke. I said, "Don't worry, everyone I test is HIV negative." Explained what the test meant. I drew his blood, and I gave him a card with an anonymous ID number for him to come back 1 week later for his results. He came back exactly 1 week. He sat down, he showed me his card. I checked the number on the card and the logbook. I checked the number on the card and the logbook. I checked it one last time, number on the card, the logbook. And there it said, HIV positive. Not only was his cough still there, he now had a fever, feeling worse. So we brought him to Johns Hopkins Hospital that evening, where he was admitted. I visited him every day for the next 3 weeks until he died of pneumocystis pneumonia. All of a sudden, being a neurosurgeon, even curing a brain disease didn't seem that important. I dropped out of my PhD program, gave up my scholarship to care for the Pauls and Anthonys of the world. The next stop was Columbia Presbyterian Hospital on 168th and Broadway in North Harlem. The only place where there was more HIV, more drug use, more urban violence than East Baltimore. There was also a new disease called multi-drug resistant tuberculosis. When I was a medical student, we spent more time talking about tuberculosis in the history of medicine course than in pathology. But I remember someone saying, they're starting to see a few cases in New York. All the TB clinic and prevention programs had been shut down. Problem was, New York City was raging with HIV. Columbia Presbyterian Hospital was right across from this place, the Fort Washington Men's Shelter, the largest homeless shelter in the world. Patients living with HIV in this setting will get tuberculosis, transmit tuberculosis in the shelter, go to the hospital for treatment, start treatment, go back to the shelter, stop treatment, get sick again, go back to the hospital for treatment, go back to the shelter. Resistant forms of tuberculosis were generated that were virtually untreatable. 19 Rikers Island guards and 1 inmate died of incurable tuberculosis. We had 1 attending physician who also died of incurable tuberculosis. And 1 medical student was sent off to National Jewish Hospital in Denver for experimental treatment. My very first paper I published in a journal showed that over the course of a 3-year medical residency training program, 1/3 of all residents would develop tuberculosis. I got in a little bit of trouble because all the private rooms had the best views of the Hudson River, and we didn't want those tuberculosis patients in those nice rooms, even though they were state-of-the-art, negative pressure ventilation is the only place you could really contain and prevent the transmission of tuberculosis. But we did, got the right people in the right rooms, tuberculosis rates started to go down. I said, this is really great, we're affecting change. I want to study HIV and tuberculosis. I think I should get this vaccine. There's a vaccine for tuberculosis. It's a debate as to whether it works or not, but if I'm going to spend my whole life around tuberculosis patients, I better take this vaccine and get whatever help it has. So before you get this vaccine, I had to get my chest x-ray. So I went to the ER, knew the ER doctor, said, give me a chest x-ray, got my chest x-ray, got it developed. Looking at him, he said, wow, that doesn't look so good. Your left lower lobe, there's a pneumonia there. That kind of, and there's a scar in your lymph node. Kind of looks like tuberculosis. So I went to the doctor, pulmonary doctor, started my treatment, and began the 2-month wait. Drug sensitive or drug resistant kind. I had been married for 2 years, started discussions of having a child, wondered, God, did I infect my wife? Thankfully, I didn't. Waited for the cultures to come back. Said, purely drug-sensitive tuberculosis. Treatment worked. Disease is gone. It really is. You're fine. Next stop was San Francisco, the mecca for learning how to treat patients with HIV. Shortly after arriving in San Francisco, miracle drugs were developed that turned HIV from a death sentence to a manageable chronic disease. But not everyone received these miracle drugs, because some thought if you give these miracle drugs to the homeless, the mentally ill, the people who were addicted, then they would miss their doses and the virus would continue to replicate. The virus would then develop mutations and become resistant to these miracle drugs, and that resistant virus could be then transmitted to others. And as this New York Times article says, doctors withhold HIV regimen from some. Failure to follow rigid schedule could hurt others, they fear. So we started a program to learn how to treat the mentally ill, drug users, and the homeless with these miracle drugs. I remember one day I was in the clinic and I was on daddy duty. I had a 5-year-old daughter named Brooklyn. She was visiting me and I was in the clinic, and I interviewed a woman named Laurie. She was an injection drug user and also a sex worker. I remember the scars on her veins where she used to inject, and she also had scars in her neck because she had used up all the veins in her arms. I finished my interview, and I turned around, and my daughter, Brooklyn, is sitting on her lap. Laurie was admiring a bracelet that my daughter had made. Not only admiring the bracelet, but asking her about every bead. Tell me about the blue bead. That's a pretty bead. But you know what? That pink bead is my favorite. What is your favorite? Brooklyn says, the pink bead, of course, just like you. My daughter was beaming. Finally, someone appreciates me in the way that I deserve. I look back and I realized that I had prejudged, I had misjudged Laurie in the same way that I misjudged Anthony. This was not a node of transmission of the San Francisco HIV epidemic. This was a mom who loved and terribly missed her 3 children that were taken away by Child Protective Services. We found that with case management that would link people to housing, substance use treatment, mental health treatment, with good adherence counseling combined with a radical simplification of therapy to 1 pill once a day, that we could bring successful HIV treatment rates from 9% up to 90% in this population. And now treating everyone with HIV is now a standard of care. But we weren't done. I had a student working with me, and she said, you're interested in HIV and poverty, that's great. But she had grown up in Africa, and she said, the real problems are in Africa. Could we start working there? After a long discussion, several discussions, I reluctantly took a trip to southwest Uganda and met doctors and nurses who were running a HIV clinic and a medical school and nursing school where there were 5,000 HIV-infected people and not a single one on treatment. Not a single one on treatment, even though prices of these medications had come down from $18,000 a year to just over $1 a day. We thought, that's not right. What happens if we start raising money? If we have enough money, we can promise to treat one person for 5 years. We should try. And so we did. And we went back to the clinic. We said, we can treat one person for 5 years. Who should we treat? They formed a committee of doctors and nurses, pharmacists, community leaders to pick one person out of the 5,000. And they picked this person here, Elijah Uzunguzi. They picked Elijah because he led a song and a dance troupe that would go out to the village and teach people about HIV prevention. Elijah would go and sing about a story of a woman who found out that she was HIV positive after returning from prenatal clinic. And they would tell the story of a woman telling her husband that she's HIV positive, and the story of the husband then beating her. And they would ask the village, who gave this woman HIV? Her husband did. Why would her husband first give her HIV and then beat her for it? The clinic said, if we help Elijah, Elijah will help others. He was dying of tuberculosis meningitis. We put him on these miracle drugs with his tuberculosis medication. After a few weeks, he became stronger. And after a few months, he was perfectly well. We were so impressed with how well he did. But not only how well Elijah did, how every person that we put on treatment did. And we measured how they took their pills with electronic pill caps and home visits. We found the only time the least educated, the poorest people in the world would miss their doses is when they didn't have enough money to make it to clinic to pick up their refill. We published these findings in a medical journal. First, I thought no one read it. But then on the Friday before Labor Day of 2003, I got a phone call. Hello, this is Donald McNeil from the New York Times. Hello, this is David Bangsberg from San Francisco General Hospital. How can I help you? He said, I read your paper. Do you think it's true? I said, yeah. And explained why. And then on Monday, 2 days later, I heard the thump on the front doorstep. There was New York Times in this blue plastic container. I opened it up. There it was. Front page, left-hand side below the fold. Africans outdo U.S. patients in following AIDS therapy. And now 19 million people are on HIV treatment with normal life expectancies. And not only that, their medications render them non-infectious, so they don't transmit the virus to anyone else. And that's why public health matters. So now I come home to Portland, where 1/3 of Oregon women are suffering from depression. We have an epidemic of suicide in middle-aged white men with a sense of despair, often due to economic loss, a loss of purpose, and they may take their lives with a gun. Seeing higher rates of overnutrition, underactivity, leading to obesity, cardiovascular disease, diabetes, and cancer. And we have been far too slow to appreciate and begin to respond to racism and other forms of hatred as a public health issue. And then we have homelessness, what everyone's talking about today. One of the major top issues of all in Portland, not just Portland, but throughout the state. When I was in high school, homelessness was a problem limited to Skid Row on Burnside. And now, homelessness, people who are without housing, are in virtually every neighborhood in Portland. The point-of-count estimate suggests that there's about 4,000 homeless people that are counted one night, but the true estimates are 2.5 to 10 times that. It's probably 10 to 40,000 people living in the Portland metro area on the streets. People are scared, just like when we first saw the gay men with Kaposi sarcoma. We are responding with fear, stigma, and denial. We just hope it'll go away. And while this is complicated by mental illness and addiction, I believe this is first and foremost an economic problem. An economic problem where rents have gone up faster than wages, and people simply can't afford a place to live. Let me illustrate that with a very simple analysis. Here are several metropolitan areas where we plot median rent and the share of people who are homeless. Here's Portland. We have more homeless than Tampa because our rents are more expensive. We have less homeless per capita in Seattle, San Francisco, San Jose, New York, and LA. We have more than Tampa because our rents are more expensive. We have less than Seattle, New York, LA, San Jose, and San Francisco because our rents are less expensive. The median rent price explains 50% of who's homeless in any given city. This is an economic problem. And it's going to get worse. There are 54,000 people in the Portland metro area that are paying more than 50% of their income on their rent. And there's a new type of homelessness, which are people over 55. The number of people who are homeless over 55 has doubled over the last 6 years. These are baby boomers who've had service industry jobs without pensions and didn't quite make enough to put into their 401k. They're too young for Social Security and Medicare, and they're just one illness away from being on the street. I have a friend, his name is Jim. He's a roofer. He's been a roofer all his life. He's 58 years old. But at age 58, he can't go up on as many roofs per each day as he could when he was in his 20s. And it's getting more expensive to live, and he's having a hard time both putting food on the table and making his property tax. If he falls off his roof and has an injury without health insurance and is out of work for a couple weeks, he's homeless. He's not addicted. He's not mentally ill. But I can assure you, when he winds up on the street, he's going to be depressed. He's going to be anxious. And he may want to self-medicate. Have a few drinks. Have a few more. He's got pre-diabetes. His sugar's a little high. Being on the street, eating bad food, drinking too much, it's going to make his diabetes worse. And after a matter of months, he's going to be as debilitated as any other homeless person who's been out there for years. This is a new type of homeless we're facing. So what do we do? Well, I think first we invest in science. We invest in science that understands how social and economic forces impact health. And there has been amazing growth in science that has changed my view on healthcare. All it has to do, who's heard of the fight-flight response? We developed the fight-flight response when we were evolved on the savanna of Africa, because when there was a lion in the distance, our nervous system would be activated. We'd become hypervigilant. Our glucose was released from our muscles to get ready to run, and our immune system was powerfully activated to prepare for an injury. That's a deeply adaptive behavior with a heavy, powerful survival advantage if it lasts just a few minutes. Well, you run away and you survive, or you don't make it. But if that level of stress continues long-term, called toxic stress, it has severe impact on not only your health, your children's health. It rewires your brain, make you susceptible to depression, anxiety, which may make you more likely to use substances. It changes your metabolism, so your glucose is high forever, and you become insulin resistant, at risk for diabetes. It activates your immune system, which increases your risk of cancer. Toxic stress is most severe in early childhood, called adverse childhood experience. This could be a form of child abuse, physical or sexual abuse. It could be loss of a parent due to sudden death or incarceration. It could be simply not knowing when the next meal is coming from in extreme poverty, or it could be the chronic stress and oppression of racism. Some of you may have high blood pressure or hypertension. If you have hypertension, your risk of cardiovascular disease is increased by 25%. And that's considered epidemiologically a really big risk. That's why we spend so much time diagnosing and treating hypertension. If you have severe adverse childhood experiences in the form of toxic stress in early childhood, your risk of cardiovascular disease is not 25%, but 200%. Your risk of emphysema is 400%. Your risk of alcoholism is 700%. And your lifetime risk of suicide is 3,000%. When I was a public health student at Berkeley, we would see that race is a risk factor for all these diseases, and we would explain it by residual confounding. We just didn't have enough information. What we didn't recognize is severe poverty, living in a dangerous environment, causing toxic stress, compounded by related racism, fundamentally changes your physiology for your lifelong health, and also changes your genes such that these health effects are transmitted to your children, which was my aha moment. This is why problems are so hard to solve. We need to double down in the science, and we can do a lot, because now we have more information on our phones of what we eat, drink, smoke, how we exercise, where we live, that we can begin to respond to these phenomena in real time. And you've heard of precision medicine, and we can move from the era of precision medicine to precision public health. We also need to train a new type of clinician. We need doctors that not only know how to diagnose and treat a disease, but understand these upstream forces to intervene and cause health promotion. We need dentists who understand that the biggest cause for poor educational performance in Oregon is untreated dental pain in our children. We need pharmacists who not only know how to discover new drugs, but know that the explosive increase in the rate of drug costs is what's driving up overall healthcare costs, and figure out policies to control these costs, but still deliver safe and effective therapy. And we need nurses who are not only expert in our clinic and our hospitals, but are frontline public health advocates and change agents in the community. And we also need public health professionals, public health professionals who come from the communities with the greatest health disparities, who understand the social forces that cause these health disparities, and have the trust of communities to make a difference. And this is what public health is all about: to advocate for a health system that not only treats disease, but also promotes health, and creates systems where our healthcare delivery systems go from realizing 98% of its profits on 2% of the 2% sickest patients, to realizing its profits from promoting health and well-being throughout the lifespan across generations. And we also need you. We need you to understand how these social forces impact health in individuals, in populations across generations. We need you to understand and advocate that addiction and mental illness are diseases like diabetes that respond to medical treatment. And being poor, with or without addiction or with or without mental illness, is not a crime. I am all in. Every last bit of me. And I hope you are too. Thank you.
David will take some questions. I do ask that if you have a question, we have you speak into the microphone so we can record it for audience members that aren't here. David, did you have one? Sure.
Thank you, Doctor. I must say you have a very, very effective speaking style, and if you're not coaching TED Talk candidates, you should be. You're very, very good. I don't have any data to back this up, but it just seems like an enormous number of young people are cigarette smokers in Portland. I'm not trying to mix it up with the vaping, which is a whole different but related phenomenon. Does the data back it up?
Yeah.
Or is this a national trend, or is it localized? And what do you, it almost seems oblivious to income. It seems like kids of all apparent backgrounds are taking it up.
Yes, you're entirely correct that of all preventable health issues, cigarettes, tobacco use, including smoking and other forms of tobacco use, is the #1 cause of preventable disease. And there are the new generation of smokers who've been marketed to in novel ways, who are becoming addicted to nicotine. Separating the health effects of nicotine from the other tobacco products, and whether vaping is safer than tobacco is work that really is we need to do urgently. But the rates of nicotine addiction are rising consistent with your impression, and I think one of our most important challenges.
I'm Gail Thiemann, and I teach in the Graduate School of Education, and my students will become teachers. And they are very concerned about the number of children that are living in homelessness.
Yes.
And so I'm wondering, from a political perspective, how we convince people that the not in my backyard for low-income, affordable housing, pods, whatever it takes to get people off the street. We have some, Portland State is doing some groundbreaking work in that area, but how do we build that momentum of getting people off the street?
Yeah. Well, let me address a couple of questions. You raised a very important point about homeless children. And the point in time count showed 4,000 people. One of the reasons we think that's so much greater is the number of homeless children in the Portland School District and surrounding county school district is several-fold greater than the number of people counted on the street. Robert, do you know the number? I saw Robert. Is he still here? Yeah. How many homeless children are there?
Well, there's 40 in Portland. There's 4,500 children. Excuse me. There's 4,500 children without a permanent address.
Yeah.
In the state of Oregon, there's 22,500. This is a 2-year-old number. 22,500 children without a permanent address.
Many of these children are more likely to be people of color,
Yes.
suffer from racism. And you can't imagine any more severe toxic stress than being homeless on the street, having food insecurity, suffering from racism. That parent may be disabled by mental illness or drug use, or may not. So I think in terms of priority problems, that we have, by failing to respond to homeless children, we are buying a whole nother generation of suffering, probably 2. So there is no more important issue. How do we respond to it? Well, I think one of my goals in talking about homeless children and homeless adults is, and talking about this as an economic problem, is try to humanize this. Because we're scared about mental illness, we're scared about addiction, we're scared about the person on the street. But to tell the stories of people who worked their lives or children and why they're in this situation because of primarily an economic problem begins to humanize the tragedy. And I hope mobilizes a response. I believe the city and the county are doing great things. They are providing permanent supportive housing with case management, addiction, mental health services. They're providing shallow subsidies. They're trying to prevent this as best they can, but they just don't have enough of a resource pool. The federal investment in housing assistance has gone down from $8 billion in 1981 to $1.8 billion today. And I think our city and our county are doing heroic things to do the best they can with the resources we have to respond. This is just, it feels just like the early days of HIV/AIDS. We are afraid, we're scared, we're trying to deny it, we just want it to go away.
And we blame the victims for what has happened to them.
Yeah.
Like we used to blame HIV, people with HIV for some moral transgression based on values
Yes.
that didn't accept them as human beings of worth.
HIV was initially called the gay plague. And the initial public health response was quarantine. We couldn't imagine doing that now. But people were mobilized, resources were identified, and strategies and systems were developed, and it's not the same problem it was. And I believe we can do the same with homelessness. It may take 10 years, like it did, 20 years like it did with HIV, but we can do the same thing. And we don't even need to discover a miracle drug. We know how to solve this. And there is no one magic bullet, but there's a whole system of things that we can do to both prevent the 54,000 people at risk of becoming homeless from becoming homeless, as well as better house the 8 to 40,000 on the street.
You make a very convincing presentation about the extent of the problem that is very eye-opening for me. But how do we pay for it?
We are paying for it.
But it's not enough.
It is not enough.
So what's the
Yeah,
solution?
yeah.
Don't we have to figure out that we're paying for it already through public, with all the expenses associated with not doing anything
Yes.
about it.
We are paying for it through the criminal justice system. We're paying it through the healthcare system, through unnecessary hospitalizations. We're paying it in the economic system, through loss of productivity. We need more resources to come up with better, more effective solutions, which requires more money. But I believe the cost investment is well worthwhile, in that I can't promise it'll be cost savings, but I can promise it'll be cost effective. We don't have debates. If you have diabetes, we don't have debates as to whether we should treat your diabetes with a medication. We don't ask for it to save money. We just ask it for it to be cost effective. We need that prolongs health and well-being, quality life years. And I believe that housing interventions will do the same and also prevent downstream costs. Where do we get the money? We need people like Robert Stoll and other people to mobilize politicians and develop consensus as to what are the best uses of our social investments, and where do we find those resources? What are the right strategies to come up with those resources?
I think I have the mic now.
Yeah, okay,
I haven't
yes.
got anything new to say, but I think what I want to say is extremely important,
Mhm.
so I will repeat it.
Please.
I know that the way we're treating the homeless now is we move them from one neighborhood to another
Yeah.
neighborhood. It doesn't do any good. They're still homeless.
Mhm.
They're just in someone else's backyard.
Yeah.
I would like to find a way to stop doing that.
Mhm.
I would like to be an advocate for what can we do to help
Mhm.
the homeless in our neighborhood? How can we make them more comfortable, to eliminate the fear? And then someone asked, what can we do? We can vote.
Mhm.
We can elect people who will have an agenda that concerns public health, that cares about people,
Mhm.
cares about kids, about education, about getting people food. Why in this rich country should anyone have the new thing called food insecurity? We used to call it hunger, but that's too upsetting to some people.
Mhm.
So we have to change the vocabulary. I think the most important thing we can do right now is get our young people to vote. I don't tell you how to vote, but take advantage of your responsibility and get out and vote. Thank you.
Very well said. Thank you. Thank you.
Last month I heard a lecture. A lady named Rebecca Costa has written a book, and she said homelessness could come to an end immediately if we would use 3D printed houses. All you need to do is it's about $7,000 and enough concrete and somebody with a 3D printer for about 3 days to finish a house at $7,000. And they don't go away. Those houses never go away. So what do you think about this? I've not heard anyone else mention it except...
Well, there is a movement called looking at micro units, and I think the story hasn't been told as to what role they play. I do agree that deeply affordable housing, lower cost units, is what's most important. In my sort of reading of the analysis out there, I think we can deliver lower cost units through what historically this was been done through single room occupancy hotels. Basically, a single room apartment with a common bathroom in a large building that would house people for $1, a few dollars a day. I think we could probably house more people in a smaller space by taking those micro units together and building them in the form of a single room occupancy hotel, as opposed to individual units over a larger parcel of land. But I agree, the concept of small, affordable units, is very sensible. It has been the solution for homelessness. The number of SRO hotels in every major city on the West Coast has been decimated, so we've lost that important housing stock.
Yes.
Thank you for your comment.
We put together your School of Public Health out of two very important elements, OHSU and PSU. The challenges you've laid out are a fabric of complicated elements. What I'd love to hear is a couple of examples of what's happening in the school. Where are you approaching these efforts? What kind of work are you doing? So that we know that we can take away with this something that lets us know that we're starting to understand and make a difference.
Thank you so much for that question.
There will be a little something afterwards.
Thank you. Even better. So the OHSU, PSU School of Public Health brings the best of biomedicine at OHSU with values of community engagement and social justice at PSU.
Yep.
We have faculty, half of our faculty are OHSU, half are PSU. I'm now starting my third year as dean, bringing these two faculties together. I not only have two faculties, I have two bosses, two budgets, two government relations offices, two foundations, two sets of legal counsel. And I feel that every other dean at each university is cheated because they only have one. But the synergy of bringing the biomedicine of OHSU with PSU's value on community engagement and social justice, that synergy is real. It is real. I'm in my faculty meetings where we have this concept of shared governance, an old PSU idea, a pretty new OHSU idea. Shared governance where the faculty are helping design and build the school based on their values. These are tough, difficult, complex discussions. But in these meetings, you can't tell which faculty is OHSU and which is PSU. They're working together. And then are our students. 35% of our students are first-generation college students. I have coffee with students 3, 4, 5 days a week. That's the first thing I do. And gosh, they knock my socks off. They have lived experience. They understand why public health is important. I don't have to tell them that. They got it. They just want the tools to go out and make a difference. And it makes it all worthwhile. What are we doing? Well, I spend a lot of time just knitting these two universities together to create a single school, and there's 1,000 uninteresting details that need to get done, all important that I won't bore you with. But we're trying to take on several of these buckets: mental health, addiction, homelessness, early childhood education, Oregon health policy reform through the Oregon Health Policy Board and CCO 2.0 to design a healthcare delivery system that provides value and not just treats disease. And I think we're making progress on all these fronts. I'm really very proud that every dean at PSU has made a major investment in homelessness and doubling down on their commitment to let knowledge serve the city to what is the most important problem our citizens describe. It doesn't matter whether you're talking about the dean of school of business, dean of the school of social work, dean of the College of Arts, which has the School of Architecture, dean of the School of Public Health, dean of class who's talking about how do we change, in our English department, how do we change the narrative around homelessness, to humanize this, to understand the forces that people go through, such that our public, our community can respond more effectively. I have never been more proud to be with a group of people to take on a challenge like this. Now, we haven't solved this, and we just are taking baby steps, but we have big ambitions, and it's going to take a long time. But every major public health problem is a 10 or 20-year time horizon. And so we need to make a 10-year commitment to this, probably a 20-year commitment to this. I really believe we have a lot of the people at the table who are firmly committed to do that. So please check in with us each year, and we'll make a step. We'll make progress one step at a time. Thanks again for the question.
So
Yes.
I currently have a mic here.
Yeah.
Dr. Molly, not surprisingly, has beat me to the question here.
Mm-hmm.
I'd like to amplify it a little bit on a more global statement. In Oregon, according to DHS data, 25% of the population residing in Oregon receives some form of Department of Human Services Medicaid support. fourth of Oregon, 1/4 of Oregon is on Medicaid support. That's a pretty astounding number. Given the economics trend of a widening gap between income and the people who comprise the 350,000 people in Oregon on Medicaid or Oregon Health Plan. My question here is, you partly answered it, but what is the vision and the priorities that you are in the process of developing, and maybe some are published, I haven't seen them, that attack this problem and understand in it the limited resources we have to solve it?
The resources aren't limited. I think Oregon is doing an amazing job. When I was in medical school, residency training, public health training, I read about the Oregon Health Plan, where John Kitzhofer prioritized what are the most important diseases and which ones are most cost effective to treat and how do we prioritize that. And then developed the CCOs, the Coordinated Care Organizations, which you're right, provides care to 1/4 of all Oregonians and half of all Oregonian children. I'm on the Oregon Health Policy Board, which provides oversight to the Oregon Health Authority. And we are in the process of coming up with parameters for CCO 2.0, which is the second 5 years of the contract. It's a really exciting time. I think Oregon did a fabulous job with our first 5 years by getting this up and running. Emergency room visits, unnecessary hospitalizations went down. Several, but not all, health outcomes went up. The most important thing is healthcare cost inflation was contained at 3.4%, which is a home run. I'll come back to that how that connects to homelessness. 3.4% home run. Now we're talking about CCO 2.0. We want to maintain that cost growth. We want to reach upstream into communities to address these social determinants in early childhood to bend the cost curve through the entire life trajectory. The CCOs are on board. I wasn't sure they would be, but they are on board. They've already done amazing things. They want to do more. So we want to change the incentive structure to reward CCOs who move upstream to invest at least 1% of their budgets in social determinants of health to bend this cost curve to promote health and well-being through value-based care. I'm really, really excited. There's some really smart people at the table. People at Oregon Health Authority are smart, committed, evidence-based, and doing amazing stuff. And I think we will see more progress over the next 5 years. Let me come back to that cost growth. We really need to understand what the projection of homelessness is going to be in the future. I bet it'll go up 10% a year. We need to make investments, like we've invested in smart, rational healthcare delivery. But we also need to know what the curve is going to look like. As I'm concerned, we could make really smart investments, and we could bend that curve, which is going to be 10% per year growth in homelessness, down to 3.4%. We know, because we've done enough analytics in healthcare, that 3.4% growth in healthcare is a home run. It's amazing. We have succeeded, and we've improved health outcomes. We could make the same investments without tracking what the bend in the cost curve is for a number of new people who are homeless. And the city could vote a bond measure or a new tax. And they could say, well, there's more homeless people today than there was before this bond or before this tax measure was a failure. But actually, it was a real success because we kept it at 3.4% rather than went up to 10%. So I think, and that's one that makes me really nervous. We can make smart, wise investments like I believe the city and county are doing now. They're having a major impact on preventing homelessness and trying to get people rehoused. But we're not measuring the effect of that. We don't know what would happen without that. And I'm worried about people getting tired and giving up. Thank you for your question.
We're getting down to the end. I'm just going to take one more question for David. You've had your hand up for a while, so Linda, here you go.
My family and I are thrilled that we have a School of Public Health now and that you are here.
Thank you.
This talk meant a great deal to me. What can I do besides leaving money to the School of Public Health? What can I do to be an advocate for you Thank you.
Thank you very much. We are building a new building, 4th and Montgomery. I'm surprised that Bill didn't mention it. We are raising money for that. We need help for that. We need help for our programs. We certainly need your financial help. So thank you. Here is our website. Here is my email, and here is my Twitter. The other way you can get involved is following us on Facebook, following us on Twitter, and participating in events just like you are tonight. We hope to address many complex, difficult issues as a role to bring people together and raise our common understanding so that we as a community and society have a more effective, more effective response. You could meet with one of our students and just go to one of their presentations, cheer them on. They love seeing people in the audience and people believe in them. We had one of our PhD, Sarah Andrea, published a paper that found that people who work in the service industry and rely on tips have much higher rates of depression and anxiety than people with salary jobs or service industry jobs that don't rely on tips. She was in U.S. News and World Report. She was in several other amazing publications, and that type of championing people like that really encourages her to be that next generation of public health practitioners to make a difference over a generation. Thank you for your question.
Thank you, David. Thank you so much. I wanted to just point out one opportunity here is that for any of these events that we put on, small or large, there's always a group of folks that put all this stuff together. It's not me. I have to say that many of the individuals in the back of the room here, Margot, Johanna, Lisa, Sarah, David's assistant, because he's got one very busy schedule. So I just want a great round of applause for those folks for putting everything together. And lastly, thank you to you. Thank you for your commitment to PSU. Thank you for your support now and in the future. This is going to go to help a lot of the great research and work that we're doing here on campus. So thank you very much. Have a great evening. If you want those basketball tickets or any tickets, you can contact me and I'd be happy to get those for you. Thank you.
Hey, Roger. How are you? Nice to see you. Thank you. Hey, Sylvia.